Let's go to third. We should be very, very clear. Third nerve. Nga yafuma apa yayamwisa brainstem, then apa ni below the brainstem apa. That is never upside down, so diagram for you to see. The top is this it's below the corti. Okay, so when it comes there, where does it go? It's inishi cavernous sinus. That's where it is on the wall. Now go to the slides. Where is it traveling? Within the sinus, first third nerve cavernous, it turns dorsal to the fourth. By dorsal to the fourth, it goes above. Okay, above the fourth. Then you've got carotid, whatever, in the lateral wall, but above. These are the causes, peripheral causes. Within the third nerve pulse is accompanied with where is this? Another slide. It's that one where it says the third nerve leaves brainstem, passes between posterior cerebral, brainstem, posterior cerebral, but those blood vessels, then and travels lateral and parallel with the posterior communicating artery of the sacral Willis. Yes, as they do that, just posterior to the clinoid process, within the subarachnoid space, the nerve may be injured by that. That's possible causes. Posterior communicating artery aneurysm typically arises at the junction of the internal carotid artery and that. Now go to the diagram. This one. So upper, it comes in between these two vessels, goes parallel, then enters the cavernous sinus. From here now, from the cavernous sinus, it's going to go through into the orbital sinus, to go into the eyeball ears, supply the muscle. What does it supply? Another slide. To be able to tell you, peripheral nerve injury. These are the possible causes. They're accompanied by signs related to that, exception. This is the cavernous sinus. It's in the wall. So on top we have the third. Then below there, this is the lateral wall of the cavernous sinus. Top third, then fourth, then 6-1, 5-1, 5-2, and 6 down. Inside. It's 3, 4, 5, 1, 5, 2, then 6 inside. So if this one 6 is within the cavernous sinus, you can see it's next to the if there is any vascular problem there, like an accident, it's the 6th one. The 6th will be affected first. Okay, these others also, depending on how much bleeding, the motivation towards the wall there.
Crossing each other. Say some are not, they're not crossed, some are crossed.
No, crossed or not crossed is not at this level. Okay. It's from the spinal cord where they are originating. Okay. I'm sure they are. Slides. Hey, one here. Let's go. Okay, let's go down now slowly. Show the diagram.
Here.
Cross projection, superior rectus submental. The principle for the China College. Oh, not here. There's no principle.
Hold on.
Corona, boy.
Okay, we can continue.
Yes.
Please ask your questions. Okay, I have a question concerning ptosis. I have a question concerning ptosis.
Doses. What is doses first?
A drooping of eyelids.
Eyelid, yes. Okay.
Eyelids.
What is the problem?
Upper eyelids.
Generally, when the eyes are blinking, the one muscle from one eye that causes the other superior, one superior rectus from the left eye innervates the other eye.
Let's see.
With the crossed and uncrossed.
Let me see. Located that spirocurriculus beneath the. This is just a location of the sentinel.
Now,
Nucleus. Wait.
about the superior rectus.
Superior rectus subnucleus, which is this is the fibers which specifically in a have cross projections. Cross projections, it means right going to. So what's the problem?
Right superior rectus has subnucleus that innervates the left superior rectus
muscle and vice versa. And that's what it is.
So meaning even when you blink it, this one is supposed to blink. If the muscle which innervates this one to blink
is coming from the other side.
It will innervate this one also so that the eyes blink together.
Oh, I see it.
Now, in ptosis, when there's a problem with the superior rectus from one eye, why isn't this other eye affected also?
My hair is not looking nice.
Why doesn't this eyelid also droop? Because the work is in tandem.
Jimmy. Oh, Daniel. Daniel.
No, when you say cross projection, it means functionally, it's this eye working, but the innervation is coming from that nucleus, which is across. In nuclear lesion, ptosis should be because they are all from the 74 going there.
Daniel.
Superior rectus is involved contralaterally and spare.
Oh.
What is that?
I think it's not clear anymore.
So contralaterally is involved contralaterally. If this is the right one, nucleus, it's the left eye. That's the meaning of superior rectus is involved contralaterally.
No, not in my book.
Laterally spared because there is this crossing over from here. Superior rectus subnucleus innervates the left. Right superior rectus innervates the left. Left superior rectus into. If you've got a right superior rectus, palsy is the left which will be affected, the muscle. While if it's there, it's the right. That's the meaning. This differentiation helps you to detect what is it a nuclear lesion or not? This one is spared, only the other one is, then you know it's a nuclear lesion.
So in ptosis, are we okay to conclude that when we have ptosis from this eye, then it's the other muscle from the other side that is having?
It means this one is there is no ptosis in this one.
Okay.
You can have ptosis in both eyes.
Mhm.
What is the cause? Maybe a peripheral cause nearer the muscles. It cannot be nuclear if both are empty. That's what it means. Both are there is ptosis, both are ptosis. The lesion cannot be nuclear. For it to be nuclear, one eye must be spared.
Mhm.
Close, go,
So
close,
when
go,
you
close.
look
Hurry
at
up.
ptosis,
Bye.
you can tell both, sometimes both like that. It means it's a peripheral lesion. Peripheral meaning it's not nuclear.
Mhm.
It's somewhere near the eyelids. So bilateral ptosis is not nuclear.
Agree.
In nuclear lesion, ptosis should be bilateral or absent. In the nuclear lesions, ptosis should be as crossed projections. Vice versa. There are lesions. But why should it be superior rectus subnucleus? Superior rectus is correct. Heading west for subnucleus gives parasympathetic input to its atrophy to sphincter pupillae.
Mhm.
The in nuclear lesions,
It's not locked.
ptosis bilateral or absent. I believe in a nuclear lesion, superior rectus involved contralateral and spared ipsilateral. It can't be in nuclear lesions. It can't be in nuclear lesions. It should be. Why should it be bilateral? Because these two nucleus are not next to each other, are they? No. Wrong statement. Should not be bilateral. You know. In fact, it should be absent. In my opinion, superior rectus involved contralaterally and spared ipsilaterally.
We can proceed.
Okay.
I don't know. There are questions.
There are questions. Oh yes, why not? I like questions. If I don't know, I'll tell you I don't know. Someone at home.
Advising others to mute their mics because
Children are making noise. You can't do it. Children, even if you want, they will just tell you off now.
muted them off. We can continue on slide 17.
There are no questions. Eh? No questions.
I don't know.
Okay. Let's go to what is called the special syndromes of the trochlear nerve. Trochlear nerve is the fourth cranial nerve. One is Brown's syndrome. In Brown's syndrome of the trochlear tendon or syndrome of the trochlear tendon sheath, it has got restricted movements of the superior oblique. Trochlea supplies the superior oblique muscle. So there is restricted movement of the superior oblique at the level of the trochlea. The syndrome may occur on either a congenital or acquired basis. It can either be congenital or it can occur later on as an acquired condition. So that's what is called Brown's syndrome, restricted movement of the superior oblique. What does the superior oblique do? elevates.
Mhm.
So there will be no elevation. Well, there is superior oblique and inferior oblique. Inferior oblique depresses. Superior oblique elevates. So there will be no elevation of the eye in that eye. That's it. Then the next syndrome, so failure to elevate there. Superior oblique myokemia. What is myokemia? Which is unilateral episodic twitching of the superior oblique muscle on one side. That's what it is. But it's trying to act to action, but it's twitching. The isolated fourth nerve palsy clinical feature clinical evaluation use the palsy Bioshotsky three-step test. Some say PAX test, but it's two people who did it. The first step is to identify the side of hyperdeviation in primary position of gaze. So you simply ask the patient to look straight ahead and look which eye appears a bit higher than the other. Hyperdeviation. The patient is looking there. This one may be slightly higher than the other one. Once in primary position. Once you identify that, identify the side of hyperdeviation in primary position of gaze. 2, this reduces to 4 the number of vertically acting muscles in the two eyes. What are the vertically acting muscles here? Right hyperdeviation, here is an example. Right hyperdeviation, possible weak muscles, right inferior oblique. Okay? And the reason is, if the right superior oblique is weak, the right superior oblique is normal, there is a slight elevation. The countering effect from the right inferior oblique, from the right inferior rectus is not there. This, look. If this is the right side, there is a hyperdeviation. Right side is the right side. It means this muscle, the right superior rectus, lifts the eyeball up. It can only do that if the right inferior rectus is weak. Okay? Right inferior oblique, this is right superior rectus. If there is elevation, this is the first, there is elevation there, this one is okay. You have to consider right inferior rectus. These two muscles elevate this eyeball. There is the right superior rectus and right inferior oblique elevating the right eye. So if there is a left hyperdeviation, in right hyperdeviation, it means the right inferior rectus and the right superior oblique are weaker. That's why there is this eye looks to be higher than normal. Equally, if it's the left eye, it means the left superior oblique and the left inferior rectus are slightly weaker. That's why the left is appearing to be higher. Does that make sense? Should. So right hyperdeviation, possible weak muscles are these to allow for that to go up. If it's left hyperdeviation, the weak muscles possible is this down here. And therefore this eye looks slightly elevated. Okay? Right hyperdeviation, possible weak muscles, right inferior rectus, right superior oblique, which is this one, left inferior, that one. Okay? This is weak, this is weak. This will appear to be higher. Do we agree?
Mhm.
Because these left inferior oblique, they work together with these muscles there to elevate both eyes up. So there is now, this is working, it's higher than the other eye. It means this is weak and this is weak. In the same eye, the muscles for depression are weak. In the opposite eye, because these are supposed to be acting together, pulling the eyes up together, it means they are not elevating as much. So these are possible weak muscles, and these are possible weak muscles for the right eye to be hyperdeviated, to be higher than the left eye. Okay? So if there is a hyperdeviation in the left, it means, what does that mean? The muscles which depress the left are weak. And also, the muscles which elevate the right maybe are slightly weak. So it's this weak and this set weak. This will be appearing higher than the other eye. Because when you're looking at both eyes for you to determine that this is at a higher level. It means maybe in the left it's not coming up to this level. Equally, in the same eye, it's not depressing to expected. So the weak muscles are the depressors in the eye, which is hyperdeviated, and the elevators in the eye, which maybe looks still normal. Those are the possible weak muscles. That's the meaning of this. Very clear. Very good. Okay, we've now determined the possible weak muscles. See? Observe an increase in hyperdeviation with lateral gaze to the opposite side of the suspected superior oblique palsy. Narrows possible weak muscles to 2. Observe increase in hyperdeviation. So when you look there or you look this side, isn't it? Then you are watching the increase in hyperdeviation of this same eye. The one we are looking at is this one. What does it say? Observe increase in hyperdeviation with lateral gaze. This looking the other side. To the opposite side of the suspected superior oblique palsy. Okay, you are looking now to this side. Lateral gaze to this side. Opposite, it says opposite what? The
Opposite side of the suspected
the superior
oblique palsy.
This was so it's this side opposite. Okay, that's where. So narrows possible weak muscles to 2. Where are the 2? Vertical rectus muscles, the superior rectus and inferior rectus, have their greatest vertical action and least torsional action when the eye is abducted. Abducted means looking outward. Adducted, the eye looking inward. So when the eye is abducted, that's when it has least torsion, squeezing out like that. Okay. So in the left what? LOTH due to hyperdeviation. In left hyperdeviation, due to paresis of the left inferior oblique, in left hyperdeviation due to paresis of the left inferior oblique, which is this one, left inferior oblique, will be worse on the gaze to the left. On the gaze to the left. We say this is the left eye. So left eye is this. On the gaze to the left is you are looking outward for the left eye. That's why I'm pointing this side. Not this side. Left eye on the gaze to the left. The left is this side. But when you look directly on the patient, you are looking. Okay. Since the left eye is abducted on gaze left, yes, on gaze left, the left eye is abducted. So it will be worse. In the left hyperdeviation due to paresis of the right superior rectus, paresis of the right superior will be worse on gaze right. If this muscle is affected, when you look there, it's a problem. The left superior rectus, this one, when you look there, it becomes a problem. So that's the pattern you follow. Ideally, there should be a Casmo card, book clinic, to work out. But once you have seen one or two cases, it's straightforward. The best way to study is practical. Once you've done one on practical, you are home and dry, as long as you understand the principles here. Okay. When reduced to two muscles after step 2, muscles remaining must conform to the following pattern. One remains with either two superiors or two inferiors. Okay? You remain with two superiors or two inferiors muscles. One is a rectus and another is an oblique muscle, and one is right eye and another one is left eye. That's what you remain with. Step 3, hypertropia weighs on head tilt to the right or head tilt to the left. So you do like this, to the right or to the left. You find the eyes going upward like that. Note, superior muscles, superior rectus and superior oblique, intort the eyes. Inferior muscles extort the eye. When the head is tilted downwards to the right shoulder, eyes undergo corrective torsion, right eye intorted, left eye extorted. When head is tilted to the right eye will be intorted by contraction of the right superior rectus and right superior oblique. They work together in effecting intorsion and neutralize each other vertical action. If one of these muscles is the paretic muscle responsible for hypertropia, the vertical action will not be neutralized and hypertropia will be worse. You need to have a case so that you go through this pattern and you will understand nicely. Looks like jigsaw puzzle, but I'm afraid the best, once you have a case like that, you go through, well, you've seen one, that's it. Questions.
Hit the mask because we'll be cutting 5 minutes again.
Step 3. Concluding which muscle is the paretic muscle. If one is left with the two superior muscles, paretic muscle is the one on the same side as the shoulder towards which the head tilt makes the hypertropia worse. If one is left with the left with two inferior muscles, paretic muscle is the one on the side opposite the shoulder towards which the head tilt makes the hypertropia worse. In each case, one muscle is an elevator and the other a depressor of the two left.
Can you be aware about the undergraduate program?
Undergraduate program
Uh-huh.
for which one?
This institution.
For this institute, they're supposed to be open in. This is what month? No, June. I think any time. They're supposed to be recruiting. I was saying June or July they are recruiting. Mami, is it a lady?
Yes.
Why don't you go to the registrar, Levi Manawasa Medical University, to this big building there, registrar's office. They will tell you. You want to know when they are recruiting?
Yes.
Yes, they are the right people.
Okay. Okay. Thank you.
Thank you, ma'am. But I'm just staying there. I will the same with my grandson. Therefore, I'm going to push it. That one man. Ladies, question time. So that's a step you follow. But to properly understand, a case, my also like that. TikTok. And normally I like myself putting this information on a chart. Clinic, oh, they shall not get the others. 1, 2, 3, checking. Once the students get to know that.
So what card do you use for the same? Is it Yosh?
Oh, for this? No, it's simply you put this information there and test on the patient. Because patients will differ. You can see my options are so you need to. This is the procedure. And once you do the procedure, it will tell you the 40 muscles. This one. There's no magic to it. So, could be my questions will go? Well, I say. Washara, 8 minutes. 1 minute. Friend of mine. This is my grandson.
Tamon, is that a question? Are you having a question?